Hello, everyone. I'm Marsha Mott, and welcome to UF Health Wellness University. We have a great webinar for you today. I want to introduce our speakers to you. Our first speaker is Dr. Angela Pham. She's a gastroenterologist at UF Health. Her primary areas of interest include caring for patients with gastrointestinal disorders, Crohn's disease, and ulcerative colitis. She's board certified in internal medicine as well. Dr. Pham graduated from Michigan State University College of Human Medicine in 2011. She went on to complete an internal medicine residency at Michigan State University and a fellowship in gastroenterology at the University of Florida in 2018. Dr. Pham has written and contributed to numerous publications throughout her career. Our next speaker is going to be Dr. Erin Vanzant. She's a surgeon at UF Health. She earned her medical degree from the University of Texas School of Medicine at San Antonio and completed her general surgery residency training at the University of Florida College of Medicine. She also completed fellowships in critical care surgery and acute care surgery at the University of Florida. Dr. Vanzant has also completed multiple other training programs such as advanced surgical skills for exposure in trauma and advanced trauma life support. She's both board certified in both general surgery and surgical critical care. Our last speaker is going to be Dr. Martin Rosenthal. He's a surgeon and the director of the Abdominal Wall Reconstruction and Intestinal Rehab Program at UF Health. He earned his medical degree from Mercer University School of Medicine in Savannah, Georgia, and completed a general surgery residency and fellowship in critical care medicine at UF. He also completed a fellowship in nutrition and abdominal wall reconstruction. Oh, lost my spot here. His expertise is in providing state-of-the-art care for patients with large abdominal wall hernias, as well as fistulas and traumatically injured patients and critically ill patients within the ICU. He has designed clinical protocols to treatment guides and patients with intracutaneous fistulas and hernias to serve as a means for rehabilitation prior to surgical intervention to improve outcomes for his patients. He's regarded as an expert in nutritional therapies to decrease inflammation and catabolism. If you have any questions for our speakers today, you can ask them at any time using the Q&A at the bottom of your screen. Simply type your question in there and we will bring your question to the end and ask it at that time. And you can submit as many questions as you like, but we only have so much time. So try to get all your thoughts into one question if you can and get that in there for us. Dr. Pham, I'm going to go ahead and turn it over to you now. Thank you.
All right, thank you so much, Marsha, for the wonderful introduction. Since she's already introduced me, I won't have to introduce myself, so I'll just go ahead and jump right in. So when I created this talk, I really had in mind the audience, which is hopefully patients who have short bowel syndrome or intestinal failure, as well as their family members, friends, and caregivers. So let's begin. So I wanted to start off with defining short bowel syndrome for those of you who are unclear on the diagnosis. Other names that you might have heard that are similar and might refer to the disease process are short gut syndrome, intestinal failure, or quote unquote short gut. Essentially, what people mean when they refer to this disorder is that a part of the bowel has been removed and that there's therefore not enough left over to adequately absorb nutrients and fluid. It can also alternatively mean there's a loss of normal bowel function, even though no bowel has been removed. Short bowel syndrome, where I really make a distinction is what I care about is whether or not you have intestinal failure, whether or not you've had bowel removed or whether you have your bowel intact. And intestinal failure in a nutshell means that a person cannot meet their nutritional needs with a natural conventional oral diet, and they need what is known as total parenteral nutrition or IV nutrition or IV fluids via a catheter for either a short period of time or chronically. So it's helpful when you start out, when you're trying to understand this diagnosis, to think of short bowel syndrome in three different ways. There is quote unquote real short bowel syndrome, which is a result of a surgical procedure and a patient has lost a lot of their bowel. There's also relative short bowel syndrome where some could be removed, but with some help from the medical team, the patient may be able to function on their own without any sort of IV nutrition or total parenteral nutrition. And then there's also functional short bowel syndrome, where no bowel has been removed, but what is there is not working properly. And for the most part, these are patients who have inflammatory bowel syndrome or radiation enteropathy, or things that compromise their absorptive capacity, but they have all of their bowel intact. So my objectives today for you as an audience is for you to be able to learn how to maximize the working potential of the existing GI tract, learn how to stimulate bowel adaptation, learn how to ensure that your family member or yourself are provided with the adequate nutrients, water, electrolytes, vitamins, and minerals to maintain nutrition, how to reduce severity of intestinal failure and its symptoms that come along with it, and also how to prevent complications whenever possible and identify them as they arise. And lastly, which I think is the most important objective of them all, is to really learn how to decrease or eliminate the need for IV nutrition and IV fluids whenever at all possible. And so I'd like to start out with just a quick 101 on the normal GI tract, because it's important to understand how it functions so that we know when it doesn't function well and you need a diet to get an evaluation for intestinal failure. So the normal GI tract begins with the mouth and teeth. Then, of course, you have your stomach, your small intestine, which is also known as the small bowel. You have your ileocecal valve, and then the colon, which is also known as the large intestine or large bowel. The mouth and teeth are really an important part of the GI tract, but people don't really mention it as much. And the reason why it's important is because chewing food well gives nutrients in your food a fighting chance to be absorbed and used by your body. The stomach is then the holding tank for your food, and it adds in stomach acid to aid in the digestive process. It also prepares food for attack by pancreatic enzymes and bile salts in your small intestine, which allows for food to be absorbed across the gut mucosa or the gut lining. And then, of course, you have your small bowel, and the small bowel has these little microvilli, which are little finger-like projections that provide extra surface area for absorption. You actually have 22 feet of small intestine, which is a very large amount of intestine. And if you were to stretch out the entirety of its surface area, it would actually cover the size of a tennis court. So very important. And then, of course, you have your colon at the end. The colon makes up about 5 to 6 feet, and it absorbs fluid and electrolytes, so really no nutrients, and on average absorbs up to 1.5 liters daily. It can maximize this absorptive capacity to a maximum of 5 liters a day if there's any disorders whereby someone has diarrhea. And due to its crucial role, even the presence of half of your colon can be equivalent to adding back 50 centimeters or 2 feet of small bowel in terms of work capacity. Lastly, the colon also is responsible for absorbing energy by fermenting carbohydrates and dietary fiber into what's known as short-chain fatty acids. And these short-chain fatty acids are a very important nutrient source for the cells lining your colon. So next, I wanted to touch a little bit on what's known as intestinal adaptation. So after anyone has a large bowel surgery, either small intestine or large intestine, over time, the remaining GI tract that is there has the ability to adapt and adjust to these surgical changes. And this can take up to 2 years. If one section is removed, other areas then adapt to pick up the workload of that missing bowel. And many factors really affect the ability of your remaining bowel to adapt and its ability to gain freedom from IV nutrition and IV fluids. And that's why it's really important to work with an intestinal rehab team to really optimize the ability of your remaining small intestine and colon. So one of the most important factors is how much bowel is left and what exactly was taken out. And so whenever you have some sort of procedure done or you've had radiation treatment or chemotherapy, it's important to really keep those records and obtain surgical, oncology, and radiation reports by contacting your prior physicians and surgeons. And this really helps the next step in terms of if you have an intestinal rehab team or any of your doctors that are later on involved in your care, help them decide what kind of testing and what kind of treatments would best work for you. And other questions to ask are whenever you have a procedure coming up is which segment and how much small bowel will be removed? Was any colon taken out? And if so, which part and how much? Was the ileocecal valve removed? And was the gallbladder removed? So there's 3 types of short bowel syndrome. Once someone has had a surgery, we usually will categorize 3 different types of short bowel syndrome. The first is an end-jejunostomy, whereby the jejunum, which is the middle part of your small intestine, is brought out to your abdominal wall, and there is no colon left. The next type of short bowel syndrome is a jejunocolic anastomosis, whereby your jejunum, which is again the part of your small intestine, is attached to your colon and is connected in continuity, and there's no ileocecal valve. And you may or may not have all of your colon left. And then lastly, there is a jejuno-ileal anastomosis, whereby you have your ileocecal valve, and then your jejunum and ileum are connected along with your colon in continuity. And it's important to distinguish between the 3 different types, because each type has a different algorithm, treatment algorithm, whereby to get optimized adaptation and get the treatment you need. So why do we care so much about short bowel syndrome? Well, short bowel syndrome, the outcomes can be pretty severe if you don't get the right treatment. So we know that the 10-year survival in patients who have short bowel syndrome is pretty dependent on whether or not they are on total parenteral nutrition. Those who are on total parenteral nutrition have a survival rate of about 40%. Whereas if you're able to wean off of total parenteral nutrition or IV nutrition, your survival rate is maximized. It's about 67%. So that's a difference of about 27%. So 27 people out of 100 have increased survival if they are able to get off of TPN. And then there's not a lot of published data on how to wean patients off of total parenteral nutrition. And as we develop more intestinal rehab teams and really standardize our care of patients with intestinal failure, we'll have more and more data and really be able to help improve outcomes in patients with intestinal failure. And so that is why an intestinal rehab team such as ours is very crucial to the survival of any patient with short bowel syndrome or intestinal failure. So intestinal rehab, what is it exactly? So intestinal rehab is important because intestinal failure is a very heterogeneous, meaning every patient is different, and it thus requires specialized individualized care. It requires the care of a combined medical and surgical team, both general and transplant and hernia and fistula surgeons, GIs, infectious disease specialists, specialized pharmacists, dietitians, social workers, and specialized RNs to really come together and collaborate and help take care of these patients. And our goal in the end of any intestinal rehab team is enteral autonomy, which is basically freedom from any sort of IV nutrition or IV fluids. Our goals are also early treatment of complications to prolong life and health, and then also education of patients and their families. And then this is our team. Our intestinal rehab team is composed of gastroenterologists, surgeons, as well as many other intestinal failure specialists. All right, so I wanted to jump on to treatment strategies for intestinal failure, what we would potentially discuss with you for your first appointment with our team, and our strategies in taking care of you from a GI or gastroenterology perspective. So first of all, I wanted to touch on some of the changes that happen to your GI tract after you have had a surgery that leads to the diagnosis of short bowel syndrome. So one of the first things that happens is gastric hypersecretion, which is just a fancy term for your stomach really working really hard to increase its acid production. So why this happens is that normally your small intestine is really responsible for sending signals to your stomach to really, halt acid production, halt any sort of fluid secretion. However, when you've had a large part of your small intestine, I'm sorry, excuse me, 1 second. So when you've had part of your small intestine removed, this signal is no longer able to be sent. And so your stomach really goes crazy and really ramps up the acid production. And this can lead to a larger volume of fluid and acid, leading to more stool and more ostomy output. Why this is also important is that this high acidity alters the normal environment of your small intestine. This acidic environment in your small intestine destroys pancreatic enzymes and causes bile salts to be less effective and causes maldigestion. Our treatment for this is usually to start by optimizing acid blockers, or what is otherwise known to you as Prilosec or pantoprazole, and then histamine blockers, which are also another form of acid blocker. And the important thing to know is that you have to have at least 50 centimeters of jejunum needed for these acid blockers to be absorbed. Otherwise, you may be faced with needing IV acid blockers in order to really optimize treatment of this gastric hypersecretion. I'm sorry, everyone, if you could hold on 1 second. Hello? Hi, this is Dr. Pham. Can I call you back? I'm in an important meeting right now, but I can return your call in about 45 minutes. All right, thank you. All right, bye-bye. Sorry about that, everyone. All right. So in order to determine whether or not you have normal ostomy output, it's really important for patients to come in knowing how much stool or ostomy is excreted on a daily basis, because that helps us determine how much IV fluid you need and whether or not you need the addition of medications to slow down your output. So we know normal stool output is about 200 milliliters a day. If you have a colostomy, the normal output should be about 200 to 600 milliliters a day. If you have a jejunostomy, it can be up to 6 liters a day. And then lastly, with an ileostomy, it can vary in the post-op stage versus a mature ostomy, how much you are releasing in output every day. Immediately post-op, it can be normal to have over 1,200 milliliters be released. However, once the ileostomy has matured, you really should be only having an output of about 750 milliliters a day. Anything beyond about a liter is considered diarrhea. And I think I always go over with patients how important it is to really journal about how much output they have a day, but we really don't really talk about how this is best done. It's really important when you are being discharged from the hospital to make sure you go home with the right containers to really help measure your stool output, and that the nurses really go over with you how to either use a urinal or a stool hat to really collect your output and measure it on a daily basis. And if you do determine, or if the medical team determines that you have increased output or diarrhea, what are the things that we usually look at to figure out why this is happening and how to troubleshoot it? Just to touch on a few causes, one of the most common causes are either an infection called Clostridium difficile or other GI infections we usually will test for. Of course, medications can cause diarrhea. There are a lot of liquid meds out there containing sugar alcohols, which may contradictorily cause a laxative effect. Drinking too much fluid alternatively obviously can cause diarrhea, especially if those fluids are hypertonic or hypotonic. I will go over in a little bit what that actually means. And then lastly, how you drink liquid over the day can actually cause diarrhea. If you down a whole liter in one sitting, that definitely will cause a rush of diarrhea. I always counsel my patients on the fact that you really need to sip liquid throughout the entire day to really optimize the amount that your body can absorb. And then of course, Crohn's, any sort of fistulas can cause increased output. And then endocrine causes such as adrenal insufficiency or hyperthyroidism are also important causes that need to be looked at. And then common questions, once we've gone through the evaluation and determined that you do have short bowel syndrome or intestinal failure, the most common questions I get from patients are, what foods can I eat? What is the best ratio of carbs, fat, and protein? If sweets can be a problem, what kinds of carbs are best? And what are isotonic liquids and where can I get them? And I'm going to touch on all of these questions for you. So first off, just to go back and talk about what kind of fluids you need to drink if you have intestinal failure. So all about fluids. So isotonic fluids basically means that the fluid that you are drinking, if it's isotonic, has the same quote unquote tonicity or concentration as the fluid in your blood, plasma, tears, and small bowel, so bodily fluids. If a fluid is isotonic, it does not draw as much water into the bowel as those high in sugar and salt. And so oral rehydration solutions like Pedialyte, which is a common example of an oral rehydration solution, is an example of an isotonic fluid. And it is really the ideal fluid to be absorbed most effectively, rather than fluids such as soda or juice or any other commercial athletic beverage. Hypertonic fluids are more concentrated than body fluids, and so they pull fluid into the bowel to make it more isotonic and therefore increase stool volume. And lastly, hypotonic fluids are less concentrated or have less salt or sugar than fluids in your body. And it's kind of a contradictory idea, but what happens if you drink the hypotonic fluid is that it pulls sodium into the small bowel, and along with the sodium travels water. And so you also end up with diarrhea or increased ostomy output if you drink hypotonic fluids. So oral rehydration solutions, as I've mentioned, are really the ideal form of fluid for you to consume if you are worried about intestinal failure or diarrhea. So oral rehydration solutions are a specialized solution of salt, sugar, and water that is really designed to enhance the absorption of fluid across your small bowel and can be absorbed even in the setting of diarrhea. So what I usually recommend to patients is starting with 1 liter of oral rehydration solution sipped over the course of a day. And if you notice that that really improves your output and doesn't lead to more diarrhea, you can then increase the amount that you drink. I will caution you, again, that sports drinks or athletic beverages really have too much sugar and too little salt, even though they're really popularized and advertised as the ideal solution. I always caution to patients, don't really drink Gatorade or Powerade or all of the other solutions out there because it is way too hypertonic for you. But what you actually can do, if patients do have access to Gatorade or Powerade, what I tell them to do is get Gatorade 2, which has less sugar, and then add a half a teaspoon of salt to it. And then it becomes much closer to the ratio that's needed for your body to absorb as much fluid as possible. And then you can also make your oral rehydration solution at home from just water, table salt, sugar, as well as baking powder. It may not taste as good, but it's much lighter on your wallet. And then general guidelines I always go over with patients are chew your food very well, increase the surface area by which your body can absorb the nutrients that you give it. Of course, if you have a colon intact, a low-fat, high-carbohydrate diet is really ideal. Too much fat can lead to malabsorption, and the colon does not really like large amounts of fat. And what happens is it floods your colon will flood itself with water to make up for that, and you'll end up with diarrhea if you eat too high a high-fat diet. For those who don't have a colon at all, you can avoid that problem because you don't have a colon left, so you can eat pretty much as high a fat diet as you want. Moderate amount of carbs, that would lead to the ideal amount of output. And then, of course, no matter if you have a colon or not, or how much small bowel you've had taken out, avoid concentrated sweets and sweet beverages. So no sweet tea, no sodas, no juices. And then, of course, eat smaller meals throughout the day. So you have to constantly eat because that gives your body the most chance of absorbing as much as possible. So 6 to 8 meals per day, ideally every 3 hours. Think of it as your job. I always tell patients, imagine you're Michael Phelps. You're like an Olympic swimmer and you need, a ton of calories a day. It is now your job to eat to make up for the fact that your body is not absorbing everything that you eat. And then the other thing, which is a little bit hard for most people to do because you've grown up drinking fluids as you eat. But I try to tell patients the best way to absorb nutrients is separate your meals from what you drink by at least half an hour to an hour. So eat first, and then about half an hour to an hour later, then drink. Limit any sort of alcohol and caffeine. And then those with jejunostomies or ileostomies, you can add salt to meals and add salty snacks due to excess loss of salt in your ostomy output. So really be heavy on the salt and light on the sugar in general. Then lastly, I wanted to touch on the whole idea of FODMAPs. So FODMAPs is a fancy term for a type of substance or molecule in your body or in food that doesn't easily get absorbed by your small intestine. It's present in most fruits and vegetables, and a lot of people know of the low FODMAPs diet as a diet for irritable bowel syndrome. In short bowel syndrome or intestinal failure, foods with FODMAPs in them can actually cause diarrhea. This is a short list of some foods with a high FODMAP content, and it's a pretty exhaustive list. And I think myself and most people would find it hard to stay on a diet without any FODMAPs in it. What I usually tell patients to do is start with a religious low FODMAPs diet, and then slowly add in one thing at a time. And you can then develop a list of trigger foods that seem to increase your ostomy output or worsen your diarrhea. And then at the end of it, you'll have a nice list of things that you can't eat, but then still a bunch of foods with high FODMAPs that you can eat. Then lastly, once we've done everything possible to change your lifestyle or avoid trigger foods, I then determine what kind of anti-diarrheal medications that we can add to your regimen to help decrease your output and get you off of IV fluids. A list of these medications that your doctor might discuss with you are loperamide, or what's otherwise known as Imodium, which can be obtained over the counter. Lamodal is prescription strength. There's also tincture of opium. This does have to be compounded by your pharmacy. So what I usually recommend to patients is there's a few pharmacies in the area, but call first to make sure that your pharmacy has tincture of opium or the capability to compound it for you. And then of course, codeine, you can take this 30 to 60 minutes before meals for maximum absorptive effect. And then clonidine is a high blood pressure medication, but it also alternatively reduces GI secretions and diarrhea. The other medications I often use are octreotide, which is an injection. Octreotide is a hormone in your body that reduces GI secretions and fluid losses. And then lastly, I will prescribe rifaximin if I suspect that patients have something called small intestinal bacterial overgrowth, which can cause malabsorption and diarrhea. And then lastly, a few things I always counsel patients on is how to take their antidiarrheal medications. Make sure to take it 30 minutes to 60 minutes before your meals and snacks, not with them, because then it's just too late to really get the absorptive capacity. Make sure you ask your doctor about prescribing medications in elixir or suspension forms. However, make sure that your pharmacist goes over these elixir and suspension forms and make sure that they don't have lactose or sugar alcohols, which contradictorily will increase your bowel output, your ostomy output, or diarrhea. And then of course, you can always crush your tablets if they're not enteric coated or delayed release, and that increases the absorptive capacity of that medication as well. Then lastly, when I've exhausted all the antidiarrheal medications and lifestyle measures, the last stop we usually have is a medication called teduglutide, or Gattex. Teduglutide is actually a GLP-2, which is a hormone that is secreted from your small intestine. It's a natural hormone that induces growth of your small and large intestine. It inhibits the death of your small bowel cells. It increases the blood flow to your gut mucosa, your GI tract, and then it inhibits gut motility. So it slows down your GI tract and allows it to spend time with the nutrients and really increase the absorptive capacity. In patients who have had a large amount of small intestine removed, you actually have a deficiency in your GLP-2. And so if you reintroduce GLP-2 by injection, this hormone, you can actually grow more small intestine. And a lot of patients who have who are on teduglutide actually are able to wean off of their IV fluids or IV nutrition. And that is a great thing. This medication has really changed the landscape of care for short bowel syndrome or intestinal failure patients. However, I will say that this medication needs to be used continuously, because once you stop this medication, your bowel will atrophy or go back to its normal state. That growth that you get is temporary and it's only there while you're using this medication, but it is safe for long-term use. And then lastly, I always go over resources that you can find after you've been to see us. I find that the Oli Foundation is extremely helpful to my patients. We know that patients who are affiliated with support organizations for intestinal failure have a higher quality of life. They have less depression, fewer line infections, fewer hospitalizations. And the Oli Foundation was founded, I think 30, 40 years ago by a surgeon, Dr. Lynn Howard, for one of her patients who actually was hospitalized continuously for 5 years after he had short bowel syndrome, after a ton of his bowel died from mesenteric ischemia. And their mission, the Ole Foundation's mission, is to enrich the lives of those living on home intravenous nutrition and tube feeding through education, advocacy, and networking. So I really, really strongly suggest that you join this foundation if you or a family member has been touched by intestinal failure. And so the Ole Foundation, as you can see, really advocates the fact that patients who have intestinal failure can go on to live very normal, productive, very great normal lives. And they have a meeting once a year for patients and caregivers, as well as providers, and it's a great way for everyone to collaborate. And there's some more information about how you can join Ole Foundation. And then lastly, shortbowelsyndrome.com is another resource that I always give patients. I actually got this book myself. You can get this book free of cost from shortbowelsyndrome.com. It's written by a dietitian, and it really gives you a lot of good tricks and tips to managing short bowel syndrome. And a lot of the information from this talk, including all the oral rehydration solution recipes and things like that, are derived from this book. And if you have any questions later on, you can always find me by email. Thank you, everybody, for joining us today. And let me know if there's anything I can do for you.
Okay, great. Dr. Zant, we're going to go ahead and hear from you now. Dr. Pham, don't forget to stop your screen sharing there.
Okay, let me see how to do that real quick.
I think you just close your, yep. That's it. And then you can turn your camera off.
All right. Is that coming up?
Yep, that looks great. Thank you.
Excellent. All right. Good afternoon. As you said, my name is Erin Vanzant, and today I'm going to be talking to you about abdominal wall hernias and groin hernias. Here are my main objectives for this talk, and honestly, you could probably make individual talks about each of these sections. But my main goal today is to at least give you a brief overview of these different things, and then hopefully provide some education as well as some information on what our team has to offer. You know, this might be too basic for some, but I think it's a good start. So I'm sure most of you have heard of hernias, but what is a hernia exactly? Essentially, a hernia by definition is a condition in which part of an organ is displaced, protrudes through the wall of the cavity that contains it. For simplicity for our talk, it will basically be a hernia is a fascial defect or a defect in the strength layer of the abdominal wall. For those of you that are kind of a visual person like I am, this is a simplified picture depicting a hernia. You can see on the left, this is the normal kind of abdominal wall layers. And then on the right, you can see a defect in that layer there in the fascia with protrusion of the abdominal contents. And in this case, it's showing a loop of bowel there. Today we'll be kind of focusing on these specific types of abdominal wall hernias, specifically, you know, groin hernias, which are your inguinal and femoral, as well as umbilical, ventral, incisional hernias. But as you can see, there are multiple different types of hernias in different locations, and this picture doesn't even depict all of them. So hernias are common, and in fact, there are more than 200,000 cases diagnosed per year in the US alone. Often they're self-diagnosed, but others are found on physical exams or performed by generally primary care physicians whenever they're doing physical exams for other things. Generally, once diagnosed, you know, when you're talking about workup, it doesn't really require laboratory or blood work, though in some cases it might require some imaging. And this can be a CAT scan, ultrasound, sometimes MRIs. In general, hernias are treated by medical professionals, and they can include monitoring or surgery to return tissue to its normal location by closing the opening. There's a bimodal age distribution, as you can kind of see here. And then in general, males are more affected than females. So what causes them really? There's several known causes. They can be congenital, which are present at birth, like in kind of the younger age group we saw in the bimodal distribution. They can be caused by traumatic injury, a result of aging. So as we age, our tissues have less tensile strength. And then anything that really kind of produces a large amount of pressure or increased pressure in our abdominal cavity, combined with kind of a predisposition. And finally, surgery is a big cause of hernias. So what are the symptoms or some of the symptoms that you might have that indicate you either have a hernia or that you might experience when you know you have a hernia? Hernias can be asymptomatic, but often over time, people start experiencing symptoms. A very common one is pain. And this can be dull, intermittent, or constant. Other common symptoms include abdominal discomfort. You can have distension, groin discomfort. You can have swelling and tenderness. But honestly, the real question people have is when should I worry, right? The time to worry is when the tissue inside that hernia becomes obstructed. Often in this case, when we're talking about, emergencies are concerned, this is when that hernia contains bowels. And so kind of indications that this is developing is development of nausea and vomiting, intense abdominal pain, especially at the location of your hernia, the inability to pass gas or stool. And sometimes the hernia can become firmer, or you can feel this classic knot in the location of your hernia or bulge. And typically, whenever these symptoms occur, we consider that an emergency, and you should generally be seen immediately by a physician. On the next slide, I'm going to show you an example of a hernia that's become obstructed and kind of left too late. It might be a little graphic for some people. There's an example on the left side of normal, healthy appearing bowel. And then you can see on the right side, this is bowel that became obstructed and unfortunately died, requiring a bowel resection. And these are the extreme cases and kind of one of the reasons why we, want you to understand the symptoms of potential obstruction, because, time really does matter in those situations. And so how are hernias diagnosed? We kind of touched about that briefly before, but typically, a physical exam is enough to diagnose hernias. Often patients will come in after noticing a bulge themselves, but again, can be found on your routine physical by your primary care or by other physicians when they're, working you up for other things. Sometimes, patients will have, symptoms that, appear to be hernia related, but are difficult to detect a true hernia on exam. In those cases, imaging may be required to fully diagnose it or evaluate it. And again, a CAT scan is a great method to evaluate a hernia presence. So if you're diagnosed with a hernia, what do you do? The first step is to see your primary care provider. They can help, confirm the diagnosis. They can also provide treatments in general, to improve comorbidities that can put you at a higher risk. They can, when we talk about comorbidities, the management of them is very important, both when talking about prevention and worsening hernias, as well when it comes to the discussion of potential surgical treatments down the road. Your primary care can also help refer you to a surgeon who specializes in hernias and hernia repairs. And in general, supportive care can be performed, which entails monitoring for changes in symptoms and size, and can include the use of supportive devices to reduce your discomfort. So how about our team? What does our team do? So our team becomes involved when you're referred for evaluation for surgical repair. Hernia surgery involves surgical repair of the weak spot on the abdominal wall so that the tissue can't push back through. There are many different methods of repair. There's both open, laparoscopic, and robotic, which uses video cameras and thin tubes inserted to the body to kind of perform surgery. We perform both emergent and elective repairs here. And both with and without mesh, kind of depending on each unique situation. Another question to be answered is why we fix hernias. And in general, there are the kind of 5 main, reasons with a 6th caveat. In general, we fix hernias to relieve symptoms, right? Your pain, discomfort, or lifestyle restrictions is a big one. To reduce the risk of bowel compromise. And those that need their hernias fixed in order to fulfill their job requirements. Often if you're truck drivers, astronauts, pilots, those kind of things have requirements that have their hernias fixed before they're allowed to continue on. For development of skin changes or obstructions, like we talked about in emergency settings. And finally, for those that really prefer for cosmetic reasons. The goals of surgical repair include reapproximation without tension. So you want coverage of stable skin and soft tissue, ideally that are innervated and vascularized. And it's important to restore or attempt to restore the integrity and to maintain the abdominal wall dynamics. Our abdominal wall plays a very important role in multiple functions, that we require for daily living. It plays an important role in respiration when you're breathing, helping you have bowel movements. It stabilizes your vertebral column as well as your pelvis when you're performing activities. And so, restoring that integrity is very important if possible. And here in this lower picture here, this is a kind of an oversimplified view of hernia repair. You can see that the hernia has been reduced and that the fascial defect, so the tissue edges have been brought back together and closed. And then this shows a piece of mesh down here that is used to reinforce the repair. Next, I'm going to briefly go over a couple of the different types of common hernias that we see. So the first one is one of the groin hernias, an inguinal hernia. They're very, very common. There are more than 20 million patients annually, and surgical repair of these is one of the most commonly performed surgical procedures that we perform worldwide. And inguinal hernias make up about 75% of the total hernias seen, and that's abdominal wall hernias. In general, the lifetime risk for development is about 20 to 40% for men and 3 to 6% for women. They're classified in a couple of ways. They're indirect or direct, depending on kind of their location. And they can be large or small. They can be asymptomatic and can produce significant pain and discomfort. So when we talk about repair of inguinal hernias, there's more than 100 different repair techniques. These include tissue repairs, open mesh repairs, laparoscopic or robotic approaches. Successful surgical treatment is performed in the majority of cases with only a recurrence rate around 11%. In general, the approach is less important than the ability to perform kind of a tension-free repair. In general, with these hernias, mesh placement has been shown to reduce the risk of reoccurrence. And here they kind of show you, this is your standard kind of open groin incision. This person specifically has had bilateral, so both sides of their groin had a hernia and had open repairs. This is a depiction of kind of a laparoscopic mesh placement and just generalized anatomy. Next, femoral hernias. So femoral hernia is another example of a groin hernia. It's far less frequent than inguinal hernias and only represents about 3% of all groin hernias. They occur through the femoral canal, which typically presents as a bulge on the thigh. Much more common in females than men. It's a 10-to-1 ratio. And the prevalence increases with age, as does the risk of complications. So in general, it's important to kind of recognize the presence of these groin hernias specifically, and they carry the highest rate of strangulation or obstruction, like I showed you earlier with the bowel compromise, kind of due to that rigid canal it passes through. And so in general, the recommendation is these are fixed and can be fixed in similar fashions to the inguinal hernias previously. Next, we'll talk about umbilical hernias, which occur at the umbilical ring, typically either 3 centimeters above or below the umbilicus. These are often present at birth. If you think back to that bimodal distribution we talked about, those children with hernias are often, inguinal or umbilical hernias that they were born with. But, they can develop gradually over the life of an individual as well. The typical, causes are, again, congenital. You can get them incisional, so where a port site has gone through the umbilicus, from excessive straining, obesity, heavy lifting, other things that increase intra-abdominal pressure. So pregnancy is a big one, as well as other like medical conditions such as cirrhosis. Repair can be performed in multiple ways as well. Here you can kind of see examples of two common performs. On the left, there's a typical kind of open incision. And then on the right side, it shows you the laparoscopic instrument placement, where we use the different instruments and tubes to fix it laparoscopically. So how they're repaired is typically patient and surgeon dependent, and the need for a mesh is often predicted by hernia size defect. The next hernias we'll go over are ventral or incisional hernias. We'll spend a little more time on those hernias than we spent the rest, because we spend a lot of our time in our practice fixing these hernias. So on the next slide, I'm going to show you some examples of real hernias, which again might, be too graphic for some people. There are several different patients with incisional hernias. As you see, they can range from small defects all the way to kind of these large protruding defects, or even what we call loss of domain, where the majority of your abdominal contents are kind of outside the true abdominal cavity. So a ventral hernia or incisional hernia is essentially a bulge of tissue through the opening of weakness within your abdominal wall muscles, kind of like we talked about before. It can occur at any location on your abdominal wall. Many are called incisional hernias because they are generally formed at a healed site of a past surgical incision. As you can kind of tell from the previous pictures, many different configurations of these hernias, and each one is unique. Kind of given the wide range of presentations, there are, as you can imagine, multiple ways to repair them, including tissue, meaning the use, of repair without mesh, where the patient's own tissues are used to close the defects, to multiple different configurations of mesh reinforcement. So why does this make up so much of our practice? Over 270,000 repairs are performed in the US per year. And why is the number so high, right? So up to 10 to 30% of patients undergoing abdominal surgery procedures develop incisional hernias. So that's about 150,000 per year. There's been multiple studies kind of performed. This is one specific one where this gentleman took patients undergoing multiple C-sections and took a look over 10 years and wanted to see who developed incisional hernias. And it basically found that about 18% developed hernias, with over half of those developing within the first year entering the study. Additional studies on top of that one have shown that primary failure rates are about 25%, with a significant increase in the risk of reoccurrence as the number of repairs or surgical procedures increases. So why were incisional hernias such a problem, right? So again, multiple studies have been performed to kind of look at different risk factors and causes for development of these hernias. There are lots of things that contribute to your risk for development. It includes, obesity, development of wound infections after surgery, certain comorbidities that increase intra-abdominal pressure, so COPD, people with chronic coughs, like I said, pregnancy, different conditions that lead to poor wound healing. This can include diabetes, smoking, the need for steroids or chronic steroid use, are things that have shown to kind of be associated with increased risk of a reoccurrence. It includes a larger defect size. For example, those over 4 centimeters have an increased risk, which can go up as high as in the 40% range. And the last contributing factor includes the technique used. So how do we repair them then? Is the answer open, laparoscopic, or how about robotic? Honestly, multiple factors influence how hernias are repaired. The patient's anatomy, the surgeon's skill set, and as well as patient preference. The most important thing is to set your first repair up for success. We have seen, that once you have a repair and you get a reoccurrence, that your chance of having a successful repair after that, dramatically decreases. So, some of that might also include, when we talk about setting yourself up for success, is modification of comorbidities prior to, undergoing your initial repair, medications, adjustment, weaning off steroids if that's possible, or weight loss. So, the standard, could go over, more on surgical repairs, but honestly, that would be probably a pretty long talk. So I'm going to kind of focus on now just kind of our standard post-operative care. We'll kind of go over complications, and some of the risk and what our team, kind of does. And if you have further questions on more of the, technical details of operations, I can certainly answer those questions later or have our email, okay? But standard post-op care for us includes, no soaking or bathing until your incisions are healed, includes bathtubs, oceans, pools, and rivers. It reduces the risk of wound breakdown and can reduce the risk of infection. Honestly, we don't believe that there's a special diet, but we do believe in, good diets. So we recommend kind of high protein to help for healing, probiotics, and of course, being active with walking. The other really important thing for us is, we typically put you on a weightlifting restriction. That's nothing greater than 10 pounds for at least 6 weeks. The idea being that it, allows your wound to heal and prevent reoccurrence. Again, anything that increases your intra-abdominal pressure puts strain on those tissues that are healing. So what about complications, right? So complications after, hernia repair include recurrence, infection, which can be both wound and mesh infections. Management of each is unique to the type of infection, the type of hernia repair you had, as well as the patient. You can also get chronic pain, fistulas, mesh erosions, and bowel obstructions, all possible complications after hernia surgery. Often the big question, to us is, what about the risk of mesh infection? Overall, the incidence is about 5 to 10% of open ventral hernia repairs and 1% of laparoscopic repairs. The incidence does go up when you place mesh in the setting of infection or previous infected fields. Often in this setting, our own personal practice is to put in absorbable or non-permanent mesh that disintegrates over time. That kind of allows support of a tissue repair without a placement of a possible permanent nidus of infection. Other risk factors for infection include smoking, obesity, diabetes, and steroids. Typically when, we perform or evaluating a patient for repair, we request that, they, read it to certain BMI or that their diabetes are controlled. Again, we talked about, can, we wean the steroids or, things that cause poor tissue healing. And we absolutely want our patients to stop smoking. Again, on the next slide, I'm going to show a few examples of these complications, and if, you kind of get squeamish, they might be a little too graphic for you. So these are, just some complications that you can see. Here, there's exposure of mesh, an underlying mesh infection. You can see it, a wide range from cellulitis here, which is a superficial infection, to also, a fistula formation where you have, bowel eroding through your wound here. So this leads me to where to go for repair. Obviously my answer is I want everyone to come see our team here at the University of Florida. But really, we all have different skill sets, and, in general, we recommend that you go to a surgeon who specializes in hernia repairs and does a lot of them. To go one further, if possible, we recommend going to a major center university setting, right? Especially if you have a complex hernia. And I say that because generally our volume of cases are higher, meaning we perform more of these surgeries. Often, these are referral centers for all major complications, which means that we've seen the entire gamut of hernias, as well as complications that you can imagine, and have experience in managing them. And, the thing is, even if you decide to go to a local surgeon and end up undergoing repair and happen to end up with a complication or recurrence, and want a second opinion, or, want to go to a new facility, we will always be more than happy to take care of you and to evaluate you. And I think ultimately the greatest benefit of at least coming to our team is that you truly get a team approach. We have a nutritionist, GI specialist that is, you've been introduced to Dr. Pham. We have bariatric service. We have, people that can specialize in aid and weight loss. We have endocrine who can help you manage your diabetes. We have wound care specialists, and all of us work together to individualize your care and give you kind of the best possible chance to have a successful hernia repair and surgery. So that's all I have for you today. I'm always, again, happy to answer questions and can be reached at the email below, or we can answer questions at the end as time allows. Thank you.
Okay, that was great. Thank you so much. We have Dr. Rosenthal up next.
Hello. All right, let's see here. Well, my name is Martin Rosenthal. Thank you so much for joining us, everybody who's tuned in right now. This has been very informative. Thank you, Marcia, for putting us all together and organizing us, and to Drs. Vanzant and Dr. Pham. They did an excellent job kind of dealing with two very complex situations. And what I really wanted to do was have Dr. Pham talk first about some of the intestinal failure stuff, and then have Dr. Vanzant talk about hernias, because now we're going to talk about a pretty complex situation that blends both of those two discussions together. And so what we're going to delve into is kind of the management of complex medical and surgical patients. And we're going to look really specifically at something called an enterocutaneous fistula. And so I was kind of perusing some of the questions, and the question came up about what is a fistula. So what we're going to do is briefly kind of review what a fistula is, see some of the guidelines that are out there, and then see kind of what's new and what University of Florida is doing and how we're going about treating these folks that have kind of post-surgical catastrophes. And without further ado, some of my pictures may be a little bit gruesome, but they're going to be very useful in kind of showing you what a fistula looks like. It's defined as an abnormal connection of one of the areas of your gastrointestinal tract or your GI tract, which comprises of the hollow viscous organs to the outside world, namely to your skin. In layman's terms, it's a hole in the bowel that diverts stool and GI contents to the skin. And so there's two different types of gastrointestinal fistulas. There's something called an enterocutaneous. Entero in medical terminology means bowel, and cutaneous means skin. So there's this line, a connection that goes from the bowel all the way up to the skin, and you can get some effluent from the GI tract spilling out on the skin. What you see here is something a little bit more troublesome, which is called an enteroatmospheric fistula. And what you see in the red stuff, that's actually the mucosal lining of your GI tract. And that becomes a little bit problematic to treat. And so what I'm hoping that you glean from this discussion from all three of us is that, we have really comprised a lot of high octane physicians and aides and social work. And we have everybody under the same roof here to hopefully provide a necessary service to our community. And it doesn't stop with just these. What we've actually built here is a way to help optimize all of our surgical patients. Anybody undergoing a major operation needs to seriously think twice about it if they're feeling, weak, or if they're feeling down, or if they're having issues, because a major abdominal operation, a major thoracic operation can actually hurt you more. So if you're coming into a major operation a little bit frail or debilitated, the surgery is not going to do you any favors. Now, I say that for elective operations. Obviously, there's urgent and emergent operations. So why does any of this matter as far as discussing more specifically about fistulas? So as you can see here, roughly 300,000 admissions a year for some of these fistula patients, 230 hospital days per year spent, $500 million as far as what we have collected, $1.5 billion in charges. So as you guys know, whatever a physician bills doesn't mean that's what we collect from insurances. 4.1% of inpatient mortality. And the crazy thing is these patients undergo at least 3 procedures or operations in that same admission. It gets to be pretty daunting. And so how do we go about classifying these fistulas? There's several different techniques that we can use. And so what you can see is anatomic. So anatomic means, is it the esophagus, the stomach, the small bowel, the large bowel, or is it going to be more the type 1? So type 1 is esophagus, or this first portion of your small bowel, which is the duodenum. Type 2 is small bowel in its entirety. So that's the jejunum all the way down to the ileum. And then type 3 is the large bowel. And type 4 was that enteroatmospheric fistula, that one that actually has that mucosal lining at the surface of your skin. There's another classification where we can look at volume. So how much of the actual GI content comes out per day, and we have to quantify it. And sometimes we have to get very creative in quantifying it. And so less than 200 milliliters a day. So a Coke can, if you think about it, is probably around 250 milliliters. So if you have roughly a Coke can that comes out and collects, then you have a low volume output. 200 to 500 is moderate, and anything over 500 is high. So 2 Coke cans a day starts putting you at risk of having kidney issues, dehydration issues. You can feel lightheaded. You can feel dizzy because of all the dehydration. And that's when you need to start making your way to a hospital setting. And then lastly, certain physicians will classify these fistulas based on etiology. So etiology, was the fistula traumatic? Did somebody stab you? Did you get shot in the belly and you got a fistula? Surgical complications, interesting, because most of the fistulas that we take care of, and I mean all surgeons that take care of this type of complicated patient, are after surgeries. So 85% of gastrointestinal fistulas are created after surgical. I wouldn't call them complications or mishaps, because oftentimes we have to operate under very extreme circumstances. So this is a consequence of doing, high caliber operations in the abdominal cavity. But we do take care of all these types of patients. Is it a malignant fistula? Do you have cancer that eroded through the actual GI tract? Is it from inflammatory bowel disease, as Dr. Pham touched on? Is it ulcerative colitis or Crohn's? Was it related to decrease in blood supply, which is ischemia? And so sometimes you can throw a clot, which is a blood clot that goes from the heart into the vessels feeding your bowel. And all of a sudden that bowel can become ischemic and it pops, and then you get a fistula. And there's multitude of other reasons. You could have radiation for other cancers that ends up radiating the bowel, and you can have the integrity of the bowel at that point is damaged by the radiation, and you can sprout a fistula. So how do we go about treating these? In the acute phase, when you first come to me and we admit you to the hospital, there's an acronym called SNAP, and that stands for sepsis, which is usually source control. So if the fistula hasn't yet necessitated out of the abdominal wall and you have GI content inside your belly, that's what we call intra-abdominal sepsis. So we really have to go after that pretty aggressively. And oftentimes we usually stick drains into the abdominal wall, or actually through the abdominal wall into the abscess that's collected into the abdomen. and we can irrigate those and actually get some of that gras doux out of the abdominal cavity. So we get something called source control. So source control is very, very important to us. Oftentimes we have to get infectious disease involved, get you on high caliber antibiotics. IND means incision and drainage. Is there an actual abscess that I can literally pop open like a pimple with a simple procedure? And we reserve surgery because anytime you've had surgery, like I told you, 85% of fistulas are created after operations. If you've recently had an operation, you want to wait as long as you possibly can to go back into somebody's abdomen, because you can cause more harm than good, because the surgery alone causes something called inflammation. And that inflammation makes it very hard for surgeons to delineate any kind of surgical planes and dissect certain things out. So it makes it very dangerous to go back in too early. But we definitely reserve surgery as a way to get source control if every other of the less invasive procedures fail, or that we can't do them. So then comes the next S, which stands for skin. So it's skin barrier or protection. Some of the effluent has gastric acid in it, or it has bile acids in it, and that can burn the skin. So we really want to have good skin protection. And that comes in the settings of different appliances that we can put on there. And we have barrier creams and we have stuff like that to help protect you. And then comes the thing that I'm most interested in, which is the nutritional side of it. So between Dr. Pham and I, we've done nutritional fellowships to help us, better treat patients with various nutritional supplements. And Dr. Vanzant will be joining us, as she'll be doing the fellowship as well. But this really, really is a multidisciplinary approach. It isn't just Dr. Rosenthal or Dr. Pham saying this is what we're going to do. We really collaborate, because this gets very complex very quickly. Are we going to be able to feed you through your mouth? Or are we going to have to put a tube in somewhere to feed you into your stomach? Are we going to have to give you specialized nutrition in your IVs as the form of steak potatoes that goes into the venous system? It gets very complex pretty quickly. And then the anatomy, I want to know where the fistula is coming from, because I know that the further down your GI tract, meaning from mouth to the bottom, the further down we go, the less output it's probably going to have. So it's going to be one of those low volume outputs. And then procedures. When do we actually have to surgically correct this? And usually that means months of waiting for that inflammation to die down. Here's what some of our societies have recommended. So ASPEN is the American Society of Parenteral and Enteral Nutrition, meaning IV nutrition and GI nutrition. And then the next society listed there is the Latin American version of ASPEN. And these are the most recent guidelines that we've had back in 2017. And since this, there have been no updates. But what I really wanted to show you, which is kind of not favorable, obviously, in our situation, but what I wanted to show you is that their first recommendation was the need to have a nutritional assessment. When you first come to me, I'm going to get your weight. I'm going to ask you, how much are you eating? What are you eating? We're going to get your body mass index. We're going to do check your lean muscle mass. We're going to check your adipose deposition, meaning your skin fat. And we're going to figure out, are we behind the 8 ball already, or do we have a little bit of wiggle room? Number 2 is preferred route of nutrition. So if you're stabilized after we got source control, you remember that sepsis source control, are we going to feed you orally? Do we have to give you EN, which is that enteral nutrition that's coming into your GI tract? Maybe not by your mouth, though. And they're saying that if you have less than 500 milliliters a day, or cc's is the equivalent of a milliliter, then you're that, low to moderate output fistula. Then maybe we could get away with an oral diet. But if you're over 500, meaning you're high output, then they're requiring us to put you on parenteral nutrition or the IV nutrition. At the University of Florida, we've developed a protocol that challenges some of this, because we found very good success in treating patients. Because believe it or not, when you start telling patients, hey, you can't eat, we're going to feed you through your IVs, there's a very much a psychological problem that comes in there. We all eat socially. When mom and dad cook dinner and we taste that meal, and we smell that later on in life, we have a somatic approach to it, and we say, oh man, that smells like the cookies my mom used to make. All of a sudden you're smelling those things, but your surgeon may have told you, hey, you can't eat that. And we think that that's a little bit more challenging than not. And so we have extended this requirement for parenteral support a little bit higher. But as you could see, and one of the things I'm going to point out is the evidence for this was very low. And so the next one is protein dosing, which was expert consensus, which is even lower than the quality of evidence. So when you have quality in medical literature, it's based off of things called randomized control trials. And out of those randomized control trials, we can actually figure out how we're going to clinically adapt our practice and our techniques to better help the public. And so when you start seeing things as low quality, expert consensus, no recommendations, and moderate quality evidence, that means that there's a lot of low-hanging fruit that people like myself and Dr. Vanzant and Dr. Pham can start studying to better help our community. So recently we've published a protocol that we put our patients through, and it's really interesting. So what we're looking at is something called enhanced recovery after surgery. That is ERAS. So this enhanced recovery after surgery approach is weighted very heavily on nutritional strategies to help fortify you before you undergo a major fistula takedown. But guess what? This enhanced recovery after surgery doesn't only apply to enterocutaneous fistulas. This enhanced recovery after surgery applies to colorectal surgery, thoracic surgery, gastrointestinal surgery, cancer surgery. It applies to everything that we do to help make you more robust, fortify you, and optimize you so that when you undergo this major operation, you're already kind of on that prehabilitated curve, rocking out and getting into the rehabilitated curve much quicker. You know, if you ever talk to a physician, what you bring to us is ultimately what you're going to get out of an intervention. So if you come to me optimized as best as you can do, you're going to do far better than you thought you would had you not actually done that prehabilitated format. So we built this prospective registry. So all the fistulas that we do, we put into a database so that we can study it. And we've built this protocol based on a pre-op, operative, and post-operative phase with emphasis on the nutritional management. So never has it been more important and more critical for us to put together a multidisciplinary team approach. You've heard this now 3 times from Dr. Pham and Dr. Vanzant. Well, I have Dr. Pham who helps me out. We have wound ostomy nurses, dietitians. A PharmD is the person who actually mixes up the bags of parenteral nutrition, that IV nutrition. We have interventional radiologists because there are certain procedures that we could do that are less invasive than surgery, although they work less frequently than the surgery. We address all wound care needs. We have nutritional optimization, and we end up going about fixing these problems for our fistula patients, for our hernia patients, for any of our surgical patients. And why is it super, super important to have content going within your GI tract? That means whether you eat it or you have that enteral support, meaning you might not eat it, it might be going through a tube that goes down through your nose into your stomach, or it might be a surgically placed tube that goes straight into your stomach. And what it does is it helps build the gut integrity. It fortifies it, right? So when you have nutrients going down through that lumen, meaning the PVC pipe that is your bowel, the mucosal lining of that is much happier. You have gut integrity that is better. There's no leaky gut syndrome or something like that. And believe it or not, it actually affects your immunity. So your colon and your small bowel all have immune cells in there. And so if you're pushing calories and you're pushing nutrients into that bowel, they can all sense what you're looking at, and they can tell you whether it's good or bad. And if there's something bad coming in, it builds immunity to that, and you go about fortifying your immune tract. In fact, they've done studies looking at people that were eating normal diets and their vaccination rate, because, you know, with the COVID-19 pandemic, those who actually eat or have enteral nutrition going down their GI tract at the time of vaccine build a better immune response, because guess what? They're building up calories that feed the immune cells so that they can actually help you build that immunity. There's something called the gut-lung axis, which we don't really need to get into, but what it does is whenever you get sick and the gut is not happy, there's an axis that can actually affect your lungs. Similarly, there's a gut-lung conduit of inflammation. So if it's inflamed, it can affect your lungs. And then the commensal organisms. I saw another question on probiotics in there. I personally believe in probiotics, but we can have a different discussion offline on whether or not I'm drinking the Kool-Aid. But I do have some data that I want to share with you as far as probiotics. Again, here's the goals of our protocol that we built. This approach is to move to address the importance of luminal nutrition and reduce or minimize TPN, which is total parenteral nutrition, where all your nutrition is given into an IV and into your veins where your liver can use it. Don't get me wrong, if you absolutely need parenteral nutrition, it is life-saving. Stanley Dudrick back in 1970s was the first person that came out with parenteral nutrition. He took the mortality associated with enterocutaneous fistulas from 85% down to about 35 or 40% just with nutritional interventions alone. And as you can see, we have TPN versus supplemental parenteral nutrition, which is the SPN. And that means that with supplemental parenteral nutrition, maybe you're not getting all your calories you can by eating. We can supplement the rest of your calories with some of the parenteral support. And what we're ultimately doing is help building you up to get you to a better place so that you can go through a major operation. So admittedly, most of our patients eat while we're giving them the supplemental parenteral nutrition. And we're engaging them throughout this entire process, whether they're absorbing their nutrients, because as Dr. Pham had said, sometimes these fistulas spring up way too close in your, way too close to your mouth, meaning you don't have that much absorptive capacity. And so despite the fact that you're eating, you might not be absorbing those nutrients. And we have ways of measuring that. We have to make sure that you're staying hydrated. And ultimately, we can use those GLP-2 analogs, those growth hormones that Dr. Pham brought up to help maybe build the mucosal lining so that you can absorb some of those nutrients. And there's tricks to this trade that are very sophisticated. This is actually interesting. The biggest thing is what this is personalized prehabilitation. So they actually took patients, made them get them on a treadmill. They helped work them out, and they randomized patients to this prehabilitated workout scheme versus patients that just sat around. Well, technically it was standard of care, because right now, if you go to any surgeon, they're going to say, okay, Ms. Smith, Mr. Smith, you're ready for your operation. Let's do it. Well, if I told you that, hey, Mr. Smith or Mrs. Smith, listen, I want you to come back to me in 6 months, but I want you to walk a mile a day for 1 month. And then I want you to walk a mile and a half a day for 2 months. I want you to get up to about 5 miles a day to build up your stamina, build up your endurance, build up your lean muscle mass. What you can see here is the folks that didn't do that process, their aerobic capacity, which is a marker of endurance, was far less. It changed from 323 to only 362, whereas the people that actually did the intervention almost doubled their endurance capacity. Endurance to a surgeon, endurance to a physician means that when we put you to sleep and go under anesthesia and you have to go under a long operations in our world is anything greater than 4 hours, you have that endurance, because when you are still asleep, your body is still going through that operation, which is a huge stressor. It's essentially that running from a bare stimulus. All your hormones get revved up, everything gets revved up. So we want you to have high endurance. Complications go down and length of stay goes down. Those are very important for our community patients. Ultimately, we have to assess your prehabilitation, where you're at and how we're going about doing that. And here are some of the markers that we use. We have amino acids, which is your protein. I can look at specific amino acid profile and look at certain amino acids. In my world, I really like citrulline, because citrulline is a surrogate. It's a marker for how well you're absorbing your nutrients. And then I want to see stable weight gain, and I'm going to help you correct all your nutrient deficiencies, but we have ways of measuring that. So now we get to kind of like the surgical phase. We've gone through letting all that inflammation die down, and now we're going to start fortifying you one last time. And this is where something very, very interesting comes into. This is where that enhanced recovery after surgery, that ERAS nutrition comes in. We give you something called immunonutrition. And what does immunonutrition hold in it? So immunonutrition has arginine and glutamine. These are two very potent amino acids because these help in wound healing. They help in decreasing wound complications. And after an operation, the biggest thing is you want to heal. Then you have omega-3 fatty acids, which is the medical term for fish oil. So you have omega-3 fatty acids, and these have been proven to decrease inflammation. And then you have nucleotides that also help fortify the system to undergo a major operation. And all you have to do is take 7 drinks twice a day. BID is medical term for twice a day. for those for 7 days before your operation, and you get this tremendous benefit. And so I tell patients, they all ask, where do I get this, doc? And so I say, go on to Amazon.com, because everybody does that. I would say that all you have to do is Google up preoperative drink, and most of the stuff that you will find are going to contain at least the bare minimum of these three right here. Some don't include those nucleotides. And then the last thing, we'll see some good literature on why we do 50-gram glucose load, or it's also a 50-gram sugar load. So here's some literature that I just want to share with you. Basically, they did they looked at 26 randomized control trials. You remember those studies that drive literature? And out of them, they had 2,500 patients. And what you see is 5 to 7 days of that immunonutrition showed benefit. 26 out of 26 of the randomized control trials here reported that there was a decrease in infectious complications by 36%. So a third of patients had a benefit. Even reported non-infectious complications. And those non-infectious complications can be very severe, such as stroke, heart attack, pulmonary embolus, where a blood clot goes from your legs to your chest, have been decreased. They've decreased hospital length of stay. And in most nutritional literature, there was no mortality benefit because you can't randomize patients to no nutrition. That is unethical. So most of the nutrition literature doesn't really look at mortality. We look more at complication rates and length of stay. And here's that 50-gram glucose load. So essentially, I tell my patients, drink about a soda can worth of apple juice in the morning, like kids, really sugary apple juice, or any juice for that matter, or you can have your own specialized pre-op drink. And what it does is it decreases insulin resistance, which is super important because in the post-op phase, we want insulin to be high. It's a growth hormone at the end of the day. And so insulin helps us to recover. But the worst thing in the post-surgical phase is having really high sugars in your bloodstream. A major surgery, because of all the hormones that it takes to run away from the bear, which is the surgery, make your glucoses go very high. It almost turns you into from a non-diabetic patient into a diabetic patient. And we have to keep up with keeping those sugars low. So this 50-gram glucose load helps you do that. And now I want to look at some specific nutrients. Some of these nutrients are very cool. So we can decrease inflammation. We can certainly help resolve inflammation. And I'm going to get into that probiotic question that you guys had as well. So this is a study that we looked at together. I worked with several very nice individuals from other countries, mainly Europe. And what we ended up looking at was omega-3. This is the Latin sign for omega. So omega-3 fatty acids, again, those fish oils given through the IV in hospitalized patients. We did a systemic review of all the literature published since 2012. We found roughly 49 studies, almost 6,000 patients. And what we showed was that patients that got omega-3 fatty acids, we had a decrease in infection rate. We had a decrease in sepsis. Remember the abdominal sepsis. Sepsis is a big term where you have an infection that is causing a systemic problem, low blood pressure, high fevers, things that we have to admit you to the ICU for. LOS is length of stay. And so we decreased length of stay by 2 days in the ICU, which is the intensive care unit. And overall, 2 days overall for the hospital length of stay. And again, the mortality was not significant because you can't randomize folks to no nutrition. And then within omega-3 fatty acids, this is really compelling literature that's coming out. 2000, a man from Mass General published data. His name was Charles Sirhan, and he was looking at the bioactive component of fish oil, so the omega-3 fatty acids. And he showed that these, what we call specialized pro-resolving mediators, or SPMs, were probably the bioactive component of why we have inflammation resolution with the omega-3 fatty acids. They're classified into resolvins, merisins, and protectins, and ultimately they decrease the endogenous pathways of inflammation. So it's not a medicine. This is a nutrient. It's a nutrient that decreases inflammation. And there's a lot of research looking at both chronic inflammation, acute inflammation. It's even looking at Parkinson's. We're looking at sepsis. We're looking at dentition. inflammatory bowel disease, joints as far as rheumatoid arthritis, and so forth and so on. There's a very compelling evidence that these specialized pro-resolving mediators are very beneficial to us. And lastly, I wanted to look at probiotics. So this is actually really, really cool in my mind. This was coming out of University of Florida. Stephen Anton is one of our friends, 49 articles they looked at. And as you can see here, look, this is what we call ARBs. ARBs are kind of like ACE inhibitors. So if you're on lisinopril, losartan, they all fall into this kind of classification of medication. It's an antihypertensive medication that has been also known to reduce inflammation. Here's your omega-3 fatty acids. I love the fact that they included that into this study. Here you have vitamin D, but in the middle, you can see probiotics. So from this line all the way down to the bottom, you can see that probiotics had the most impact in older patients over the age of 65 at reducing inflammation as far as a nutritive or a nutrient, because this IL-6 and CRP are biomarkers. I can take some of your blood, I can send it to the lab, and they'll send me back these as a lab result. And these labs would be reduced in patients taking probiotics. They were all compounded. If you took omega-3 with probiotics, you'd have even further reduction. So these are very compelling evidence that probiotics, omega-3 fatty acids, and even what your physicians prescribe to you actually all reduce inflammation. So in summary, the acute, subacute, and chronic, and even the surgical phase of treating enterocutaneous fistulas, and even those enteroatmospheric fistulas, needs to be evidence-based. But unfortunately, there's scant levels of evidence out there. The last publication or the last update that we had was back in 2017. Before I gave a very similar talk to a bunch of to a medical community at a society meeting, I actually went back 15 years, and there was only 2 studies published in the past 15 years dealing with enterocutaneous fistulas and the management of enterocutaneous fistulas. That means going forward, we have to have experts willing to look at this. Thankfully, the incidence or the actual prevalence of enterocutaneous fistulas in society is pretty low. So having this devastating pathology isn't really that high, but the incidence, the amount per year, is actually going up. And that's because it has to do something probably with the amount of surgeries we're doing each year is going up. But we can also make inferences from other bodies of literature. Combination of adequate nutrition and exercise will equate to a better prehabilitation. And this is also true for any major surgery. I'm happy to discuss this further if need be. When it comes to intestinal failure, hernias, and fistulas, this whole one size does not fit all. But we at University of Florida believe that we have a one clinic does fit all. And under the University of Florida Abdominal Wall Reconstruction and Intestinal Rehabilitation, the UF Clinic, we're always happy to see anybody to help fortify you before any major operation, in particularly the fistulas and the intestinal failure, and even the hernias. And then specific nutrients can help decrease nutritional resistance from inflammation and allow for a likely longer period of anabolic growth. And anabolic growth is building muscle. And when we build muscle, that means we get stronger, we get back to our baseline faster, we shorten that rehabilitation period, and you're back to living your life like nothing ever happened. So what else do we offer with this UF clinic? And this is kind of going to be the end of my talk, and then we'll be happy to take further discussion. Here's an enterocutaneous fistula. So at the University of Florida UF clinic, we have built an entire city around taking care of patients like this, like hernia patients and intestinal failure patients. And here you can see, these are the team members. Dr. Vanzant and Dr. Pham don't need any introductions, but Dr. Al-Mansour is a minimally invasive specialist who does a lot of robotic and laparoscopic surgeries. Dr. Chim is my plastic surgeon who can actually take muscle flaps. If the hernia is too big to close primarily, he can take muscle flaps and put that on after we shrink the hernia down to as small as we could possibly get it using surgical techniques. And then he puts a little muscle flap on top just to completely close up the hernia defect. So we could take care of what we call loss of domain hernias, where a lot of the majority of the gastrointestinal content is outside of the body or in that hernia sac. Additionally, he could do different tissue repairs and muscle flaps to close other types of hernias. Dr. Janice Taylor is actually a pediatric surgeon but in a very critical role in the pediatric world because she does intestinal failure in the pediatric group. And when her pediatric patient population graduates and goes into the adult classification, that's when Dr. Vanzant, Pham, and myself will take care of the patient, and they'll be enrolled into our clinic. And Dr. Badusky is actually a new member of our team. He's a transplant surgeon. And so one of the coolest things that we have now is if everything fails, if Dr. Pham and Dr. Vanzant and myself can't really get you through it as far as intestinal failure, he can do an intestinal transplant now. And there's not too many institutions that do intestinal transplantation. Ironically, in the state of Florida, there's 2. And I think there's actually only less than 10 that do them nationally. And then on top of that, if your hernia is so big that myself or Dr. Pham can't fix you, or Dr. Mansour can't fix you, with the help of Dr. Chim, I can use Dr. Badusky, and we can collaborate, and we can actually do an abdominal wall transplant. So this is all very innovative stuff that's coming to the University of Florida, and we're building this program very quickly. And I would say most of the resources and everything is already here. We have about 85–90% of everything that we need. The abdominal wall transplantation is the last little lid that we need to complete our team, and we have the man who's going to do it. So here are the disease processes that we can take care of. Everything from hernias, fistulas, and intestinal failure. And these are different things that you may have read about or seen, as well as some of our members are board certified in critical care, and we can take care of most anything in the ICU as well. So if you have friends or family that need ICU or have critical need, we're happy to take them as well. And lastly, we've built up this protocolized medicine, this ERAS approach that we've been talking about to blend state-of-the-art nutritional optimization with these immune-enhancing formulas to help fortify all of our patients. We've built up multiple different clinics to help get your comorbidities abated and get them checked and optimized as best as we can. And we've standardized our operative technique to help build this community and to build how we're going to ultimately go about treating each of these patients. So that way, if something goes wrong, we know exactly where it broke down in our system. And lastly, the rehabilitation and early mobilization to help get you back to your baseline as quickly as you can. I do appreciate all your time. You know, it takes a city to take care of some of these patients. The more complex it gets, the more I would recommend going to a university setting, because despite the fact that we have residents and everybody and trainees at various levels, we have all of our consulting groups underneath the same roof. We have everybody that we need in order to take care of you. And without the influence and without the backing of Ed Jimenez, our CEO, without the backing of Dr. Parker Gibbs, our CMO, or Chief Medical Officer, and without the backing of our chairman, Dr. Forsmark and Dr. Upchurch, this entire service line for our community wouldn't be possible. They give us the administrative support in order to bring together really high caliber experts so that we can collaborate and build this service, build this program so that it impacts the community in a positive way, and we can actually take care of patients better than most anybody else. And so I do appreciate your time. I do appreciate everybody's questions that have already asked questions. And without further ado, we're going to try and get to some. I'll give it over to Marcia to help us out. Thanks, guys.
All right, we got a lot of questions here. I apologize again if I ever say some of these things wrong. So someone asked about, can you do do you ever do a muscle transfer instead of mesh for an inguinal hernia?
So for inguinal hernias, what it boils down to, truthfully, is how big the defect is. I have patients that have hernias where their small bowel, their large bowel, and even their kidneys have been down in their hernias before. And in that case, yes, we do need tissue to help fortify the area that we're operating on. I would say 80 to 90% of all inguinal hernias, we could just primarily repair and fortify our repair with a piece of mesh. One of the questions that I saw is what type of mesh? And so when we do our mesh selections, we look at level of contamination. And so if it's a clean case, meaning all you're doing is coming in from home, and there's no infection involved in the area that we're operating on, you don't have pus anywhere or anything like that, we do use synthetic meshes because they're more durable. They last in your tissue the rest of your life, and they're inert. The types of meshes that Dr. Vanzant and I use are largely inert, meaning your body does not react to them. You don't mount an immune response, and simply put, it's woven together fishing line, but medical grade and sterilized. If it's a contaminated area, meaning a loop of bowel died, like that picture that Dr. Vanzant shared with us, or there is active infection, or I'm going in because somebody else already has an infection or a mesh infection there, then we can talk about primary repair, meaning using your own tissue, or we talk about using a biologic mesh. And biologic meshes are a little bit more expensive, and they're not quite as durable, because what ends up happening is essentially it's either pig skin or it's sheep skin. And what they do is they give it a chemical bath that takes away all the different cells that are in our skin. And what's left behind is collagen. And collagen is what we have in our own skin. And so you have a collagen matrix that is a mesh that we use to help fortify our repair so that you don't immediately get a hernia back. But what ends up happening is you have vascular ingrowth into that tissue, and you essentially turn the collagen that the pigs and the sheep gave to us to your own tissue, which over time can be weakened as opposed to the synthetic meshes. I don't know if Dr. Vanzant might have something else to add to that.
No, I think you covered that pretty well, and our practices are very similar.
Okay. I had another question that maybe is a good one for Dr. Pham. What does the ileocecal valve do?
Sure. I actually did not touch on that very much during my talk, just due to time constraints. The ileocecal valve is actually an extremely important part of your GI tract. It basically prevents reflux of colon contents back into your small intestine, and actually acts as a barrier between your small bowel and your colon. And if you lose your ileocecal valve, it predisposes you to small intestinal bacterial overgrowth due to the fact that there's no separation barrier between stool and luminal contents. And that is a condition that does predispose you to increased ostomy output and diarrhea. And so it's important to know when your surgeon goes in whether or not he or she took out the ileocecal valve, because that can predispose you to certain things that you wouldn't otherwise have if you still had your IC valve, in a nutshell.
Okay, thank you for that. We had a question submitted as well. Said, I have a bulging hernia. It's about 4 by 5 inches, an excisional hernia. I'm 8 months post-op from a cholecystectomy. Is surgical repair really my only option?
Surgical repair would be your only option to fix that area. Yes, if it truly is a hernia defect. Really nothing else works to kind of bring your tissues back together and to fix that bulge. There's no medications or really physical therapy or rehab to do to fix that. Your tissues don't grow back together at that point over time. So my answer would be yes.
Okay.
Just to piggyback after Dr. Vanzant. So we do know that over time, as we age, the tissue decreases collagen, decreases elastin. And so what that means for hernias is over time, hernias will expand, they will get bigger. And so the bigger they get from a surgical standpoint, the harder it is to fix. The smaller ones, we can oftentimes do as a same-day operation. But if we're getting into doing tissue reconstruction, bringing in Dr. Chim, doing major, 4 to 6 hour operations, that usually buys you about a 5 to 7 day hospital stay. So if you have a hernia and you're like, I just kind of want to watch and see where this goes because I really don't want an operation. Truthfully, nobody wants an operation. I'm a surgeon. I don't want an operation. But at the same time, what we say is like, if it's symptomatic, certainly consider getting it. Now, how big and how quickly it gets big is going to be dependent on what you do for activity and dependent on your genes. And so some people expand very quickly, and then we do have to do something about that. Whereas other people may have more robust tissue and better genes, or they lift lighter stuff, and their hernias may progress very slowly over time.
Okay, we've had a couple questions about hysterectomies. Does a hysterectomy, whether you had it robotically maybe or laparoscopically, does that put you at a larger chance of having a hernia?
Yes, so if you do it robotically or laparoscopically, you would probably have a smaller incidence of a hernia just because the incisions are going to be smaller. Versus the traditional open approach, which is a small, what we call a fan and steel incision, the one that we can bury down below the bikini line. Those incisions are a little bit bigger, but cumulatively, the robotic and laparoscopic approaches probably can equal the size of that fan and steel incision, the one that goes below the bikini line. And so if you take all those different incisions and add them up, you can see that you still can get a hernia with either approach, but I typically think the actual hernias are probably going to be a little bit less with laparoscopic or robotic approach, just because where those incisions are, they're going to be a little bit smaller.
Okay, kind of along that line, can childbirth bring on a hiatal hernia?
I would say with the different pressure gradients, yes. As the gravid uterus grows out of the pelvis and the guts start going up, you can certainly have different pressure dynamics within the abdominal wall. And so, you know, just because we talked about incisional groin hernias, umbilical hernias, inguinal hernias, stuff like that, you know, what you're describing, a hiatal hernia or a paraesophageal hernia, is still going to have a pressure gradient associated with it. So tissue weakness and the different pressure gradients can contribute to springing a hernia anywhere within the abdominal cavity. So yes.
Okay. Someone asked about, what about the long-term damage from PPI medications for someone who maybe has Barrett's esophagus? Should they be on a probiotic?
That's a very complicated question, actually. I think it's kind of two-pronged. I'll attack the first portion first, which is the long-term damage of PPIs. Certainly, any medication, if you take it for too long, can cause long-term damage. But where we care more is whether the benefits outweigh any sort of damage, long-term damage a medication can have on you. And we take a look at the disease process and whether the disease process untreated has long-term damage as well. And in a process like Barrett's esophagus, it's a precancerous condition. And so worst case scenario, Barrett's esophagus can cause esophageal cancer. And so I would say, comparing the worst case scenario of esophageal cancer versus the long-term effects of a PPI, I would say the long-term effect of a PPI is much less than having esophageal cancer. And if I had to choose, I'd rather be on long-term PPI. That being said, if you do not have Barrett's esophagus, yes, most certainly I would really talk to your doctor about seeing if you can get off of the PPI. But in the face of Barrett's esophagus, depending on, you know, how advanced the Barrett's esophagus is, for the most part, I think your only option really is PPI, unless you can surgically remove or otherwise treat the Barrett's esophagus and eradicate it completely.
Okay. Someone asked a question about, are there any permanent limitations on activities at 8 weeks after a hernia repair?
I personally don't limit people beyond that. You know, kind of as we alluded to, you know, if you're a person that's, you know, prone to hernia formation, or, you know, you, let's say elderly, or, you know, depending on kind of your tissue quality, anything that repetitively increases your, you know, intra-abdominal pressure, increases your, you know, risk of developing recurrence or other hernias. But, you know, for me personally, lifestyle, you know, and like quality of life is the most important thing. And so I think for me, you know, when I counsel my patients, I say, you know, if you can limit these things, do it. Otherwise, you know, if it's important to your quality of life, I would not limit anybody after that time frame. And Dr. Rosenthal, I don't know if that's any different for you.
No, I 100% agree. You know, at 8 weeks, your wound is pretty much healed about 85% of what it's going to do. There is tissue remodeling that can occur still, even up to about a year or 18 months, depending on what's kind of going on with your body. So after 8 weeks, the limitations, I guess the limitation should be lifted. If somebody's telling you differently, I would ask them why. And if it's something that they can easily describe to you, then maybe follow their input, but 8 weeks is plenty of time. In fact, some people even say 6 weeks, but Dr. Vanzant and I like 8 weeks just because it gives it a little bit more time for that scar tissue to build up and for your cells to really start growing into the mesh if we use a biologic mesh, and ultimately gives you every chance for this not to become a recurrent hernia.
Okay. Let's see. Someone asked, how do you schedule a consult or an appointment to have your condition evaluated for an upper abdominal hernia?
We have our clinic
Process started, really.
Yeah, I think we have our clinic phone number on that very first slide.
Okay, I'll put that up at the end again too.
Yep. Additionally, we all have our email addresses on our slides, I think, so you can email us. And what else? Ultimately, we're happy to see everybody. So the referral system can be a little bit tricky to navigate. We see everybody from any insurance group to no insurance. So don't think your insurance is going to have a part to play in this. The biggest thing is maybe have your primary care physician put in a referral to see us, especially if you're coming from the villages, because University of Florida now owns that hospital. So the primary care physician can actually start getting that ball going. You just ask them which physician you really want to see, and that should be straightforward. Otherwise, email one of us and we can certainly help expedite that process.
Okay. And just in case anybody's curious, the phone number we're going to call is the 352-265-0535. Is that correct?
I think so.
Sounds right.
Yeah. That's the number that's listed for you. So Dr. Rosenthal, so I figured that's a good spot to start with. So okay, we still have a few more questions, and some of them, I know many of you have submitted some great questions. They're very in-depth questions that I think are maybe a little bit too challenging to get into in a situation like this. So I'm going to ask you to either reach out to your own physician and or reach out to our doctors as well, or go ahead and schedule an appointment, because some of them are just a little bit more than we're going to be able to address here, as well as we're running over on time. So I want to be respectful. I know you guys have busy schedules and other things to get on to. So I want to thank everyone for joining us today. I appreciate you taking time out of your busy schedules. I thank the audience for attending as well. And thank you so much, everyone.
Absolutely. No, thank you.